Hello, everyone. Good morning, good afternoon, and good evening to some of you even. Welcome, everyone, to today's webinar, Preterm Optimization in Practice, Insights, Innovation, and Realities from a UK Tertiary Center. I am Yue. I'm the Marketing Manager for Maternal Infant Care from GE Healthcare, and we're very delighted to have Dr. Alex Cleator with us today as our speaker addressing these important topics. So Alex is a consultant neonatologist at Liverpool Women's Hospital, the largest specialist hospital in Europe dedicated exclusively to women's health and newborn care. So as highlighted in the invitation, Dr. Cleator will share the science behind the core preterm intervention, demonstrates how collaboration drives better outcomes, and discuss both successes and challenges from frontline practice and, of course, how they tackle them, or supported by real-world data. And aside topics, as well as we approach World Prematurity Day next Monday on the 17th, this session is also an opportunity for all of us to amplify our voices for the little ones worldwide and explore how we can deliver better care from every angle, from every stakeholders. So before handing over to Alex, a quick reminder and housekeeping here. Please don't forget to use the Zoom chat to submit your questions or comments. We'll be able to address them together during the Q&A after the presentation. And we will be expecting discussions as well to see how the practices may be similar or various in different countries. So with that, Alex, the floor is yours.
Thank you very much, Sue. Good morning, good afternoon, good evening to you all. It's an absolute pleasure to be asked to talk today. As you said, my name's Alex. I'm a neonatal consultant at Liverpool Women's Hospital in the UK, and also the lead for preterm optimisation on the women's site. Absolutely fascinating topic to talk to you about, and so many different areas to cover. And what we're going to have a think about today is a reminder, which I'm sure a lot of you will know, as to why preterm optimization is important. We're going to have a little look about what that looks like here in Liverpool. What model do we use to address optimization of the preterm? We're going to have a refresh of the evidence base around the different optimization interventions, and also focus on some of the challenges that we've had locally and some of the big successes as well. And hopefully by the end of this, give you some food for thought to take back to your neonatal units, your local hospitals, to think critically about your optimization data and how you can influence the care of these mothers and babies. So to give you some background, Liverpool Women's is a level 3 neonatal unit. We have around 9,000 births a year with approximately 1,000 admissions to our neonatal unit, both from our own hospital and as referrals from across our region. We were very blessed in 2019 to have a brand new shiny neonatal unit with lots of space per cot, as you can see in the picture, that allows us to practice family integrated care really well. And most of our parents spend the majority of their time next to their babies. And we can still get a nitric machine in or an echo machine, and we can still do what we need to do and work around that and have the family there most of the time. And we have 48 cots in total, 24 intensive care cots, high dependency cots, and 24 low dependency cots. In addition to that, we also work alongside Alder Hey Children's Hospital, and opening next year is a further 22-bedded intensive care surgical neonatal unit. Each cot will have its own ensuite parent room, an absolutely amazing build, which obviously links in immediately into the regional cardiac, surgical and neurosurgical centre. Currently, if babies are born at Liverpool Women's and have a surgical problem that needs an operation, they have to go into an ambulance half an hour up the road to Alder Hey. And then often backwards and forwards again many times during their neonatal stay. So this new unit at Alder Hey will remove the need for that constant transfer and allow us to look after babies on either site. So our team is rapidly expanding. It's a very exciting time, but that gives you a bit of a context of what we're doing at Liverpool. The population that we serve is very interesting. The majority of the patients who come through our door are in the lowest quintile for social deprivation. So a very, very mixed population, but an absolute privilege to look after these local families. In terms of preterm optimization, where has this come from? And you're probably all quite familiar with this, but the national improvement work in the UK focused on preterm optimization has been running since 2017. And it was adopted into element 5 of Saving Babies' Lives in 2019. Saving Babies' Lives, a set of local criteria which we had to provide evidence for that we were compliant with in Liverpool Women's Hospital for the interventions that we know make a difference in outcome to mothers and to babies. They expanded that further in 2023 to version 3 of Saving Babies' Lives, and the preterm optimization interventions now play a massive element in that. So we have to justify that we are compliant with all of those interventions, and we are doing our very best to make sure that mothers and babies are receiving these evidence-based interventions that we know make a difference to outcomes at the end. And so much so that it's part of our CNST maternity incentivization scheme. So if we do these things and we get these interventions to mothers and babies, there is financial benefit for that to the trust as well. So not just in the best interest of our babies and families, but it's worthwhile as a hospital that we think about this very, very carefully. So how do we think about it in Liverpool? Well, back in 2022, we set up our preterm optimization group, which we affectionately call POG. And following on from the setup in Liverpool Women's, it's now active across the entire Northwest region. It's a multidisciplinary group that meets once a month, every month, and critically reviews the care of all mothers and babies born at less than 34 weeks of gestation, which is the focus of what we're talking about today. That group reports to the Family Health Divisional Board within the hospital and does lots in terms of education and broadcasting out of the learning that comes from these meetings. You can see on the bottom of your screen that it is truly an MDT group. Neonatologist, obstetrician, our advanced neonatal nurse practitioners. The group is very much a platform for trainees to get involved in quality improvement initiatives and to learn about how to look at and interpret data. It includes our local data leads for neonates and for maternity, as well as midwifery staff and our lead preterm birth midwife. So we often have between 12 to 15 people on these POG meetings to look at the care that we're giving. And the way that we do that is we have a summary slide to start with for each baby. So here's an example, and the obstetricians will present a brief summary of the care, and then we will talk about the various areas of optimization and whether we met the specific criteria for that mother and baby. Some babies will be eligible for all of these optimization interventions. The more mature ones will not necessarily be eligible, but we will talk about whether or not they receive them. If they did, what went well. If they didn't receive them, why didn't they receive them? So if the baby arrives on the neonatal unit cold, why did that happen? We look into the care. We study trends that we've seen in previous POG meetings, and we generate QI as a result of what we're seeing. So in some cases like this one, there may be one or two things to talk about. In other more complex cases, such as this one, where there wasn't a full course of antenatal steroid, mum didn't receive IV antibiotics or deferred cord clamping, there has often be a lot to talk about and a lot of learning from the obstetric and neonatal side of the equation, and lots of learning to generate and QI to have a think about. When those QI projects are generated, a team of people will go off and work on that QI, and they will report back monthly into POG, and we relook at our data and see how things are progressing. We have made really quite big improvements since 2022, and you'll see our data shortly that supports that. We currently look at these 9 preterm optimization intervention measures. So as a reminder, these are the measures that we know make a difference to the outcome for preterm babies, and there is an evidence base behind all of these that we think quite critically about. This is what's happening in Liverpool since, well, back on 2018, as you can see. So the blue dotted line is Liverpool's compliance with preterm optimization interventions. So this is the percentage of women that have received all of the optimization interventions that they are eligible for. The black dotted line that you can see is the national average, and the grey shaded areas are the interquartile ranges. The red data at the bottom of the chart is missing data that they were unable to interpret. So you can also see, since we started our preterm optimization group in 2022, including our data leads for neonatal and maternity, we've now eliminated missing data by involving them in how we look at the data, how we address any gaps where we kind of find that missing information. And in terms of the number of women and babies who are receiving all interventions, we're doing pretty well at Liverpool when you compare us on a national level. So we're going to kind of go on a bit of a whistle-stop tour of those interventions and remind ourselves about the evidence base and what we should be thinking about. The first one, not so much a problem for us in a tertiary centre, but certainly something that our local neonatal units have to think about, is that babies need to be born in the right place. Specifically, singleton infants who are less than 27 weeks, multiple infants, so twins or triplets who are less than 28 weeks, or infants with an estimated fetal weight of less than 800 grams. Our data, our evidence shows us that the above should be born in a maternity service on the same site as a tertiary neonatal intensive care unit. We are not bad in the Northwest. 85 to 87% of our babies are born in the right place. And those babies who need to be transferred to Liverpool Women's or a similar tertiary centre are done so effectively the majority of the time. Why? Well, we know that for every 20 babies that you transfer to a tertiary centre who should be there, under 27, under 28-week multiples, under 800 grams, you will stop one of them from dying. So a number needed to treat of 20. So it's a pretty powerful measure. In addition to that, you reduce their risk of significant IVH and their risk of NEC and periventricular leukomalacia. Our transport team, Connect Northwest, who move these babies across the region, have shown by attaching accelerometers to the babies' incubators that if we're moving these babies postnatally rather than in utero, we subject them to significant accelerative and decelerative forces when they are in the incubator in that ambulance. And within our region, the longest transfer that we have is potentially 2.5 hours from a district general hospital to the nearest tertiary unit. And that's presuming that a bed is available and they don't need to go further afield. So we should be doing everything that we can to move these babies in utero. As a result of that, we've set up a new working group earlier this year, and we've talked about our in utero transfer audits. We've had a big focus on refused IUTs when the tertiary centre says, I'm sorry, we've not got a neonatal cot or we do not have a maternity bed. How can we better think about solving that problem and making sure that the highest risk babies are coming to us? And we're currently overhauling our in utero transfer guideline at the moment. So things to think about for this intervention measure: how can we prevent the refusal of IUTs? And there's some discussion in our Connect Northwest team at the moment as to whether we make it mandatory to take certain high-risk babies, so universal acceptance, if you like, and how that model might work in our region. Who makes a decision in your hospital to refuse an IUT? There are cases when the neonatal consultant or obstetric consultant may not even be aware of this. It might be a shift leader making the decision in the middle of the night. Can we have better communication between the obstetric and neonatal teams on site when discussing refusals? And another element which we're working on pretty hard at the moment is, what do we do for the women who present locally at 22 and 23 weeks of gestation, at the limits of viability? And we need to have a discussion about whether mum would like survival-focused care, or whether actually, given the history and given good counselling, she decides to stay at a local hospital and have comfort-focused care if she delivers. And what we are now doing is encouraging the DGHs, the district general hospitals, our local neonatal units, to dial into the tertiary centre day or night and involve the obstetrician and neonatologist in a virtual counselling session to make sure that that family is truly informed and can make a decision about whether or not we need to move that mother to a tertiary centre for active management at 22 weeks. So technology is creeping into our into what we're doing all the time, and that's now part of our national preterm birth guideline. Antenatal steroids has been a big topic of discussion lately. And back in 2022, NNAP, so our National Neonatal Audit Programme, that we submit all of our local data to, and we see how we're doing compared to other units nationally, have given us a criteria that all women under 34 weeks should receive a full course of antenatal steroids no longer than 7 days prior to birth, and ideally within 24 to 48 hours of being born. This is one of the measures that we find the most challenging to address during our preterm optimization group sessions. It used to be that any full course untimed before birth would tick that box, and we used to be at around about 80% compliance. But now that the course has to be in the 7 days prior to birth, that percentage has dropped nationally and sits around 50–52% quite consistently. Why? There's probably a number of reasons for that. There remains a steroid hesitancy, in particular to giving repeat courses of antenatal steroids, which we'll come on to in a moment. There are a lot of women who present in near established preterm labour who it's too late to get a full course of antenatal steroids on board. And there's uncertain risks of when some of these women may need delivering. And nationally, there has been ongoing concern about exposing babies to repeat courses of antenatal steroids. And that has led to some very interesting discussions in the last few weeks and months at Liverpool. So as a reminder, antenatal steroids are one of the most powerful intervention tools that we have. And the more preterm you are, the more powerful that is. So for babies under 26 weeks, for every 8 to 10 women that you treat with a timely course of antenatal steroids, you will stop one baby from dying and significantly reduce the rate of death, NEC, and significant intraventricular hemorrhage by the percentages that you can see on the screen there. The benefits of steroid plateau quite early on and do not exceed 7 days. So if you get beyond 7 days from your full steroid course, there is a real worry that you've not got that benefit on board anymore, and you should be thinking about giving a repeat dose. There was a lot of reluctance to give steroids to women who were perceived to deliver imminently. So women who came into the maternity assessment unit and were progressing very quickly and were either going to have to go for a C-section or were likely to deliver in the hours ahead. They were often not given any antenatal steroids, and it was written in the notes that no time for them to work. There has been studies this year, this one from February 2025, which shows about the minimum duration of exposure to a single dose of steroid. And actually, if you can get this dose in even within hours of the baby being born, there is benefit, with a 1% relative increase in survival for every hour that goes by. So at Liverpool Women's now, if a preterm baby presents in the maternity assessment unit and delivery is felt to be imminent, mum is given a dose of intramuscular steroid, irrespective of how soon we think she might deliver, for any benefit that we may get from that. But there is a big concern about repeat courses of steroids. And when we've discussed this with our obstetric colleagues, it became clear that the evidence for that and why there was reluctance to give repeat courses differed between all of the consultants here at Liverpool Women's. So we've dug into that a little bit further. There was a meta-analysis done back in 2019, which was very clear that said giving repeat doses of corticosteroids to women at risk of preterm birth reduces the likelihood of their babies needing respiratory support. And that should be limited to a maximum of 3 courses. And it was after 3 that we saw the negative effects on growth and neurodevelopmental outcomes. But that giving certainly 1 repeat course was thought back then to be safe. But we battle with this constant balance of the neonatologist wanting to have more steroid for the benefits of respiratory morbidity, and the obstetric team worrying about the effects on fetal growth and neurodevelopment, and where we sit in that kind of equilibrium. We know that Cochrane have looked at repeat doses of antenatal corticosteroids for women at risk of preterm birth. They looked at a large number of women and babies and concluded with quite high certainty that if women remain at risk of preterm birth, giving another course of antenatal steroids reduces their risk of RDS, lung disease, and a composite of serious neonatal outcomes. And they followed these babies up to early childhood and there is no adverse effect on their neurodevelopmental outcome to give them a second repeat course. So we are presenting this data locally and thinking carefully about which women this would be eligible for. But we have seen a shift, if you like, a creep based on a NAP specification to get a full course of steroids in within 7 days of birth. And what is happening is women are getting dose number 1, and there's a real worry that they're going to deliver before 24 hours have passed. And that second dose of steroid that should be being given at 24 hours is now being given earlier and earlier. And we are now seeing commonly that women are receiving steroids at 12-hourly intervals. There's been some publications on that this year from Catherine Pettinger and Sam Oddy to show that we really need to be thinking carefully about that. The Northwest, where Liverpool is a particular offender for that, and we have quite high rates of 12-hourly steroid administration. People think they're doing really well. Surely that second dose of steroid, even if it's at 12 hours, will have a beneficial effect on lung maturation. And we get the tick for the NNAP data and the Saving Babies Lives data for getting that full course on board. But there has to be real caution. The studies that have looked at shorter courses of antenatal steroids provide little, if any, justification for using a shorter dose, and in fact suggest a tendency towards harm, with increased rates of NEC demonstrated in some of that cohort. So the question should not be, are we giving a full course of antenatal steroids? It should be, are we giving antenatal steroids, and are we giving them 24 hours apart? And in the UK, if we adjusted our data to look at 24-hourly dosing, our compliance to that would certainly be a lot lower than we're seeing at the moment on NNAP and Saving Babies' Lives. This is our current antenatal steroid compliant with 12 or 24-hourly dosing at Liverpool Women's, and we're currently sat on a 2-year average of 52%. Our Saving Babies' Lives has a stretch ambition of 55%, and we're currently sat around the national average of 52. We have local optimization dashboards that allow us to compare ourselves to other hospitals within the region quarterly and over year periods to see how our counterparts are doing. And what we see is that if a hospital in the region is doing particularly well on the dashboard, we will often get in touch with their unit and ask what are they doing, what are their local guidelines looking like, how can we develop our care further at Liverpool Women's if another unit is doing something innovative or clever. This is the NNAP caterpillar chart for timely antenatal steroids for Liverpool, and we're sat where that black dot is, just above 50%. The red lines are tertiary level neonatal units, the blue lines are local neonatal units, and the grey lines are SCBU, so level 1 units. So Liverpool is sitting just above the national average, but again, if this chart was reconfigured to look at 24-hour steroid dosing, we'd probably have quite a bit to think about. I'd also encourage you to really interrogate where your data lies. So you can see here, antenatal steroids as a whole for under 34 weeks. Liverpool is the blue and pink dotted line on the top of this graph here. And you might go, well, great, you're above the network average, which is the dark blue line, and you're above the level 3 average across the UK, which is the green line. But then when you break it down on the bottom of the screen by gestational banding, you can see that actually in the 22 to 27 weekers, which is arguably the babies who need it the most, Liverpool were below the national and the similar unit level. We were significantly above for those babies above 28 weeks, which then when you combine that as an average, could falsely reassure you that you were doing okay. So we dove into that area even further. We looked at those 22 to 27 weekers, and there were 87 babies over the period that we looked at, born to 79 mothers. And we're, again, across a mix of gestations, as you would expect, given the fact that we're a tertiary centre. And about half and half. So half of them received a full course of antenatal steroids and half of them didn't. So we focused on the ones who did not. 5% of them received no steroid at all, and they were all unavoidable. They were born in the back of the ambulance or in the foyer of the hospital with no time for any antenatal steroid. The ones who received a partial course all presented within 12 hours of delivering a baby. So we couldn't have got the steroid in within 24 hours, even if we'd wanted to. but nearly 20% received an early course of steroids and did not get a repeat course prior to delivery. In 6 of those cases, it wasn't considered at all. In some cases, it was considered and not given. In some cases, it was declined by the patient. But with comments like would not have had time to work and not for more steroids as had at 22 weeks. And this was in a baby who was born at 26 weeks of gestation. So there's further thought that needs to go into our rescue steroids, and there's now an SOP being developed locally about when to give repeat steroid courses for our women. So in summary for steroids, it's very variable practice. And we need to interrogate the data and have a look at how you're doing for different gestational bands. But also, and what has now opened up a massive piece of work, is we have found that at least a third of the women who are presenting prematurely to Liverpool Women's Hospital are presenting within 12 hours of delivery, therefore making it impossible to optimize them with a timely course of antenatal steroid. More so, when we looked at that third of women, over half of them had been sat at home for at least 6 hours with symptoms of spotting abdominal pain. A lot of them thinking that this was normal and could be addressed in a midwife appointment the following day. So we're now having a look at our antenatal education programme and what we can do to better raise the awareness of signs and symptoms of preterm birth. So magnesium, we know that our standard here is that all women giving birth before 30 weeks should receive magnesium sulfate within the 24 hours prior to birth. And this is a loading dose of 4 grams followed by an infusion until birth or for 24 hours if mum doesn't deliver. Why? Well, we know that for every 37 women that we treat under 30 weeks, we'll stop 1 baby getting cerebral palsy if we give them magnesium sulfate. And if given less than 24 hours prior to birth at under 32 weeks, reduces that risk of cerebral palsy and death without a risk to mother or baby, apart from making mum feel absolutely terrible. It's a cheap drug. It travels quickly across the placenta. We have it in a prescribing set with antibiotics here that can be done at the click of a button, and it's available in pre-made bags in the delivery suite fridge, so it can be grabbed pretty quickly and given when this mother has intravenous access. Our magnesium sulfate data is pretty good and usually sits somewhere between 90 and 100% as an average over the last 12 months, and we keep a close eye on that. Antibiotics, we know that all women in established preterm labour should receive prophylaxis against group B streptococcal infection, irrespective of whether they've ruptured their amniotic membranes. And we know that if we give 10 GBS positive women antibiotics who are in preterm labour, we will stop 1 baby getting invasive GBS. And as a reminder, that risk of death from GBS is significantly higher in preterm babies than it is in term babies. So we really have to think carefully about infection. Antibiotic rate and the data that goes in to saving babies' lives is notoriously difficult to get right. And we have made a preterm labour prescribing set. We've done admission and discharge competency assessments with our neonatal trainees to make sure they're putting this data in accurately into Badgernet, which is our electronic data record. And a real reminder to our neonatal staff about where to find this information about antenatal steroids. There's lots of ongoing discussions about this, but the data that we have for prophylactic antibiotics is always challenging. It's difficult. So moving on to the more neonatal aspects, deferred cord clamping. We know that all babies born under 34 weeks should have their cords clamped at least 60 seconds or more after birth, apart from when there are specific indications to justify earlier clamping. We know that if you manage the cord well, it reduces the chance of death in preterm babies by nearly 1/3. And that number needed to treat is around 30 to 50 for preterms generally, but as low as 20 in the very extreme preterms if you defer the clamping of the cord. The only reasons not to do that would be the need for maternal resuscitation in the face of massive hemorrhage, and we just need to clamp the cord and go, or if there's evidence of acute twin-to-twin transfusion syndrome. We used to not clamp the cord for monochorionic twins, and there was a worry about whether or not we should be doing that. But last year, the obstetricians at Liverpool Women's reviewed that data, came to POG, we had a discussion about it, and we now defer cord clamp all babies, including monochorionic twins, unless there is evidence of acute twin-to-twin transfusion at the time of delivery. So for any monochorionic twins, we have a discussion with the obstetric team, and if they're happy that there is not acute TTS, then we will do deferred cord clamping at that delivery. Our deferred cord clamping rates in Liverpool are very high, and some of the highest nationally. And we have achieved this by using the Life Start trolley. And you can see there, so the black blob, again, is Liverpool Women's Hospital. So one of the best tertiary units in the UK for our rates of deferred cord clamping. Deferred cord clamping links to temperature control, and the Life Start trolley, which I'm going to touch on, is what we use to achieve both. So we know thermoregulation is very important and goes hand in hand with deferred cord clamping. We know our babies need to have a temperature between 36.5 and 37.5 when they're admitted to the neonatal unit, and that hypothermia is an independent risk factor for dying. And one of my predecessors, Bill Yoxall, always told me, which has stuck with me forever, that babies may be born hot from a background of chorioamnionitis, but they are never, ever born cold. Cold babies is something that we do, something that we cause. And for every 1 degree below 36.5 that a baby's temperature drops, their mortality risk increases by up to 30%. This is something that we can actively do something about. So we bought in the Life Start trolley to try, and this is back in 2017, to try and improve our rate of deferred cord clamping at delivery. So for those of you who've not seen a Life Start trolley before, it looks like this. It's a little heated mattress. There is an ear puff IPPV device attached on the side, and it allows you to come right up close next to mother and allow the baby to receive deferred cord clamping whilst keeping them warm, and if necessary, providing those initial inflation breaths and ventilation breaths whilst the baby remains attached to the cord. What is important to say is that the Life Start trolley is what we at Liverpool have chosen to use. You can equally achieve the same impact by using a resuscitaire. And I know that we're on a GE webinar now, but we also have the Panda resuscitaires at Liverpool as well. And if we can't get hold of a Life Start trolley, we'll wheel the resuscitaire next to mum, drop the side down, slide the tray out, and you can get exactly the same effect for being able to get to baby's airway while still leaving them attached to the umbilical cord and still keeping them warm. Now, the only way that we managed to do this, again, is by very carefully looking at the data when we started to bring in use of the Life Start trolley. And we noticed initially that when we bought in the Life Start trolley in 2015, 2016, our rate of admission hypothermia went up quite significantly. And maybe somewhat not surprisingly, we were bringing the baby out onto this platform for 2 minutes to leave them attached to the umbilical cord, and these babies were getting cold. So we introduced a quality improvement project to think about how can we keep them warm during that time whilst making sure we get the deferred cord clamping and allow a delivery room cuddle. So a delivery room cuddle is something that happens with every single preterm baby at Liverpool Women's. Even if they've been intubated, they go to mum for a cuddle prior to leaving the delivery room. And we monitor the temperature very carefully. The way that we do that currently is we take at least 3 auxiliary temperatures in the delivery room, 1 as soon as the baby's been born, 1 before cuddles, and 1 prior to leaving for the neonatal unit. If it's been a particularly extensive, lengthy stabilization, an airway that's been difficult to manage, we've got the tube and we've had to give surfactants, they've had issues saturating, we will do more than 3 temperatures. But there will be a member of the nursing team who will quite carefully be monitoring thermoregulation. We are looking about whether we can use servo probes to automatically adjust the overhead heat on the resuscitaire as the stabilization progresses. And that's something that we're having a think about and looking at the moment. What do we do when the babies come off the Life Start trolley? So they've had the 2 minutes of deferred cord clamping. Is that we have some gestational parameters that we use. So if the baby is under 32 weeks, they go into this Neo Help bag, this plastic bag on the right here. Before we got these NeoHelp bags, we used to literally use kind of food grade polythene wrap or food bags from almost the same as food bags from supermarkets to put these babies in to keep that heat and moisture trapped close to the baby's body. But we now have these bags that we have a little Velcro zip on the front. They're like a kind of plastic hoodie, really. We use a drawstring to pull the bag over the top of baby's head, and the umbilical cord pokes out through the Velcro if we need access to that. We use trans warmers, which you can see underneath. They're the little heated, if I go back, these little heated gel pillows that you activate the disc inside and put underneath the baby. And then we have the GE resuscitaires and the GE shuttle, which clicks into the front of a resuscitaire and allows us to keep the overhead heat on transit to the neonatal unit. So we ran a massive quality improvement project to look at how do we address hypothermia with bringing the Life Start trolley in. We were very strict about gestational parameters, so under 32 weeks for using the NeoHelp bag, under 30 weeks for using the trans warmer. And if the baby had a temperature of under 37.0 prior to leaving the delivery suite, we used the shuttle to power the overhead heater for the journey around to the unit. We developed these pathways, which we have adjusted multiple times, and this project is ongoing and always rolling at the moment. As to if the temperature is this, do this, if it's this, do this, and lots of education within the wider neonatal team. And essentially what we managed to do was pretty much eradicate admission hypothermia. And even now, the babies that are not in range for their temperature are all hyperthermic. And we probably have 1 or 2 babies a year out the 1,000 that were admitted to the unit who are cold, because our policy and protocol for managing them is so strict. What we are struggling with now is that some of them are actually coming in too hot, and we're now looking at for our pathway of how to take away some of that thermoregulation support to get these babies into an optimal range when they arrive on the unit. That's what our admission normothermia rates look like for the last kind of year and a half. And again, those ones who are not at 100% are hyperthermic babies. We have a thermoregulation group, and that thermoregulation group meets every month, and they also attend the POG and feed back in. If a baby arrives on the neonatal unit that's either got a temperature too high or too cold, the group does a focused look at their care. They ask the team who are at the delivery for ideas as to how they can improve, or anything that went well or could have or didn't go so well, and look at it on a case-by-case basis to keep those rates of thermoregulation really good. So things to consider locally is the way that our data got better is by really quite critically reviewing cases for babies that arrived outside the normal range. Can you maintain high rates of deferred cord clamping and delivery room cuddles whilst maintaining normothermia? The answer is you can. Whether you use a Life Start trolley, whether you use a resuscitaire, you can get high rates of all of those. You just have to have a real careful eye on your data and have an ongoing QI project that does these plan, do, see, act cycles to make changes and monitor the data that's coming back. And do you have pathways for addressing low or high temperatures in the delivery room? How do you act on those? What do you do? Breast milk now, so we're onto the neonatal unit. So baby's being optimized by the obstetricians. We've done the best care that we can in the delivery room, and they've now arrived onto the neonatal unit. One of the key ones is early maternal breast milk. So we want all of our babies under 34 weeks to receive breast milk within 24 hours of birth. Some of the other guidance that we have says that milk should be in within 6 hours or even 2 hours. And we know that there is a lot of data to say that the earlier that mum expresses and the earlier that she gets this colostrum, the higher the volumes of breast milk that she gets in the days ahead, and the better her chances of exclusively breastfeeding that child. We all know that there are tons and tons of benefits of early maternal breast milk. You could do an entire talk on that. Benefits to baby and benefits to mum. So it's something that we need to do and think really carefully about. We seem to be currently at a little plateau with how successfully we are achieving this. Liverpool and the Northwest have some of the worst rates of breastfeeding in the whole of the UK, which is hypothesized to be linked to the social demographic group that we serve. So there is a lot of work going on in the unit to think about how do we improve this. Our rates are usually around about 75% for getting breast milk in within the first 24 hours. And as a preterm optimization group, we've been having a think about how do we improve that. There's now express impacts on delivery suite and up on the fetal medicine unit, and to start to introduce this concept quite early on to mums. And we've done education for all of our staff during Preterm Optimisation Week, which is every November and is currently running now with a real focus on education. So we go off around delivery suite, theatre recovery, the maternity base. We quite openly bribe staff with baked goods and various other goodies to get them involved in education sessions to talk about the benefits of milk for mum. And we've had multiple lessons of the week for nursing staff in our neonatal unit about the importance of documenting conversations about colostrum. One of the issues we've had in the preterm optimization group is when we look back in the notes to see what conversations were had with mum, documentation about expressing is notoriously absent, and we're doing work to think about how we improve that. One of the projects that we've brought in the last couple of months is the Pit Stop project, which we heard about during a conference from another neonatal unit in the UK down in Coventry. And the concept that all babies, so all mums who has a baby that goes to the neonatal unit will be taken via that neonatal unit on their way to the postnatal ward. Previously, they were asked whether they would like to go and see their own baby, which feels like a bit of a bonkers concept to me. And it was often, oh, well, you're in a bit of pain or you've had some bleeding and you're tired. Why don't we take you to the postnatal ward? Why don't we give you some tea and toast? And then we'll take you over to see your baby later. So we've removed that as an option now. And the pathway is that they will go via the neonatal unit on the way to the postnatal ward. And the midwife caring for that mum will stay with that mother on the neonatal unit for a 20 to 30-minute pit stop. And in that time, they will get an update from a senior member of the neonatal team, a member of the nursing staff, and also be supported with expressing at the cot side. We're having a look at our first lot of data for this at the moment. It's only been running for a couple of months, but we've already had a number of mums who we've successfully got colostrum in that 30-minute pit stop. And we've got some confidence knowing that it's been successfully implemented. So we're hopeful that will do something for our rates of early milk. We've now got a standard operating procedure for how that works, and that's all been through the maternity and neonatal governance structures to approve that. We've also introduced this idea of immune boost. So for colostrum to be seen as an immune boost rather than just nutrition, if you like, and for almost to be seen as a drug that we would give. So it's now appeared on the bottom of our drug cardexes. Yes, we are still a bit old-fashioned and archaic, and our drug prescribing is done on paper on the neonatal unit. So staff have to sign and date for the first time that they've given buccal colostrum. So to try and think of it as a medication alongside hydrocortisone, caffeine, nystatin, Labinic, all those other things that we give our preterm babies, colostrum should be seen as important and as an immune boost. So these two projects have started in the last couple of months, and we're going to see what impact that has on our data moving forward. Caffeine, we are pretty good at. We know that babies under 30 weeks should receive a loading dose of caffeine within the first 24 hours of birth. We know that if you are born prematurely, you are more likely to have apneas due to that immature respiratory drive. And there is concern that those apneas and periods of hypoxemia, what that does to your neurodevelopment moving forward. So caffeine is a methylxanthine. It stimulates that respiratory drive and reduces those incidences of apnea of prematurity. Our caffeine within 24 hours is high. It's nearly always 100%, because it's on that initial list of drugs which we prescribe and give in those first few hours of baby's life. The instances where we've not achieved that are usually for babies who come over and sadly die very quickly, or when the caffeine dose hasn't been recorded properly on Badgernet, where our electronic record system, where this data is pulled from. So we don't really have many issues with our caffeine prescribing and administering. And we know that if you give caffeine, it probably reduces BPD, PDA, and motor impairment. There's some suggestion of higher doses giving more benefit, but we know that when we go up on the dose of caffeine, the baby gets progressively more and more tachycardic. It's acknowledged that evidence is of low certainty about higher doses, and they need more RCTs, more research, and more investigation into the long-term outcome assessment. There's a question about why it improves BPD. For me, my understanding is that if your baby spends less time having periods of apnea and needing to receive IPPV, they're less likely to have an increase in their respiratory support or be intubated, leading to better lung health and less inflammation, and a better picture out the other end in terms of their lung health and their BPD. So caffeine is always something that we should be thinking about, and hopefully within the next few years we'll have some more data to know whether higher doses are beneficial in this cohort. And then finally, the final intervention option that we look at is volume guarantee ventilation. We know that babies under 34 weeks who need to go onto a mechanical ventilator should be commenced on volume targeted or volume guarantee ventilation. That controls the volume of gas that we are giving rather than just giving a pressure and not really paying attention to the volume that pressure is getting into the lung. We know that if we use volume guarantee for every 8 preterm babies compared to pressure limited ventilation, then we will stop one of them getting an outcome of death or BPD. And if we give it to 11 babies, we'll stop one of them having a severe interventricular bleed. So pretty significant intervention again, and reduces the rate of pneumothorax and how long they spend on a ventilator. Over the last 2 years, we've done a big regional project. A lot of our local neonatal units were still using SIMV or PCAC without volume guarantee. So we went out on a bit of a roadshow around the Northwest and did a lot of local education. So all of our regional centres are now using volume guarantee. So our babies are getting the best possible start from that point of view. So that's really a whistle-stop tour through the 9 different intervention measures that we talk about. A bit of an emphasis that the only way that we can do this is by having an active, functioning, multidisciplinary POG. We are currently in the middle of a preterm optimization week at the moment. We've got a different intervention focus for each day. Today is deferred cord clamping and thermoregulation. So we've got lots of our ANMPs going around the neonatal unit and the delivery suite, targeting staff to get familiar with the Life Start trolley, to talk about the benefits of deferred cord clamping, to talk about our thermoregulation pathways with umbilical cords mimicked as fluffy sweets that staff can then eat afterwards. So there's lots going on. There's lots going on social media. There's drop-in sessions, there's quizzes. And on Monday this week, which I would really encourage you all to have a think about, is we had a big regional event at Liverpool Women's Hospital where we invited every hospital from across the region to come and talk about optimization. There was a real focus on steroids and in utero transfers for this one, but this is our 3rd annual event. And some of the discussion and feedback on these days is invaluable. Hearing about what other hospitals in your region are doing with regards to optimization, you can hear those ideas and collaboration, networking, thinking about, well, what can we do better? That's a really good idea. We're going to bring that back to our next POG and going to have a think about this. So my summary from all of this is that preterm optimization is both challenging and incredibly rewarding all at the same time. You've got to have an MDT approach. You cannot do preterm optimization as a neonatologist or as a neonatologist and neonatal staff. You have to be on board with the obstetricians and the midwives. You have to have a POG to think about your data. Interrogate it, think about it critically, use the data that you're getting to drive quality improvement within your workplace. And I would really kind of emphasize and stress, get your local networks involved, share your learning, share your successes and your challenges, and think about how you can improve together to better the care that we're giving to these mothers and babies. That's all I've got to say. My email address is there, always happy to chat with anybody who might want to about anything that I've said, and I'm obviously looking forward to any questions or debate that there might be on the chat. Thank you very much.
This is great, Alex. Thank you so much. This is absolutely brilliant. I do believe that all of us has been learning a lot as well, and really from these real cases, from the whole process that you've been going through. And we do have a lot of questions coming up all of a sudden, actually. Uh, so, are you able to see them?
Yes, I can.
So, yeah,
Um,
maybe you have answered some of them during your presentation.
I can see there's a question about in the Netherlands, we aim to have all babies less than 32 weeks born in a tertiary centre. What type of hospital does a singleton 28-weeker go to in the UK? Yeah, it's a great question. So if you're 28 weeks, you're born in a level 2 neonatal unit. So these neonatal units are often local neonatal units. They are attached to district general hospitals. They will be managed by consultant paediatricians, so not necessarily neonatal experts like the tertiary centres. But if they are able to provide very successfully care for 28-week singletons, we have to draw the line somewhere, and there has to be a bit of an arbitrary cutoff. But if they are 27 weeks and under, the data tells us nationally that those babies do better when they're transferred to a tertiary centre. So 28 weeks and no other major congenital issues, they would be born locally. If they were born locally and were then found to be unexpectedly poorly, then we would have to move them to the level 3 centre. But most of the time, they do very well. Who is responsible for the transport if born outside of a tertiary centre? Oh, interesting. So in some places, we as a neonatologist will go and transport them. We have a dedicated neonatal transport team called Connect Northwest. They are based right in the middle of our region. So they have an office in Warrington. And they also have their own Northwest ambulances that are specially adapted for carrying transport incubators. So if we need to move a baby from either a level 2 into our level 3, or from our level 3 up the road to Alder Hey for an operation or neurosurgical input, we would ring the Connect Northwest team, and they would send one of their neonatal doctors and a neonatal transport nurse in one of their ambulances to pick our baby up and move them to where they need to go in the region. It's a very, very busy service, Connect Northwest, one of the busiest in the UK, but that model of neonatal transport services is similar to what happens elsewhere in the UK as well. I couldn't see the full list of the MDT involved. I could just see the first 3. Yes, I can certainly go. I can certainly go back to that. So it has to be multidisciplinary. When we first started this, it was very neonatal heavy, and we ran into a lot of problems with that because we just didn't have the sway to make changes on the maternity side that we wanted to make. So there is our group. So a consultant neonatologist and a consultant obstetrician. We have advanced neonatal nurse practitioners and trainee doctors in both obstetrics and neonates. So those trainees and the neonatal nurse practitioners, they prepare the data for POG every month. So they look on our network dashboards, they look on our local electronic recording system on Badgernet, and they pull the data into the slide groups for discussion at POG. We then liaise ahead of the POG meeting with the data leads for neonates and maternity, and they come along to the meeting as well and talk about some of the challenges we have with extracting our data and what it might actually mean. And then also our preterm birth midwives and senior midwives as well. Hopefully that makes that a little bit more clear.
Awesome. I see a lot of thank you as well in the chat. And we do have some questions in the Q&A. There is from Mohammed, have you considered incorporating flow sensors into the resuscitation equipment, particularly the TP circuits, to help monitor for potential hyperinflation, especially following surfactant administration? These devices could provide more precise feedbacks on delivered tidal volumes, which might support safer and more consistent ventilation in the delivery room.
Yeah, it's an absolute great question. Thank you. We have thought about it. We've thought about it quite a lot, and we thought about whether we use a device that helps us that we can connect to the end of the ET tube, and we know that there are devices available on the market for that. What we've opted for, which we've actually just bought in for very, very extreme preterms, those babies born between 22 and 24 weeks, is we've actually invested in a transport ventilator that can deliver volume guarantee, essentially. So as soon as we've intubated the baby in the delivery room, they would be connected to a transport ventilator, essentially, that can deliver our 4 or 5 mils per kilo and regulate that tidal volume. You're absolutely right. There's a real worry when you give that dose of surfactant and you keep your pressures at 20/5 or 25/5, you are giving unregulated tidal volumes into the lungs of that baby, which we absolutely do not want to do. We may explore a different device in the future, but we're going to see how we go with this transport ventilator for now.
Great. And there's another note from him as well. How consistent is the use of volume-targeted ventilation in your unit? Although most preterm infants are initially started on VTV, I often see it being switched off with the explanation that the baby did not tolerate it. I also prefer using the term volume-targeted rather than volume-guaranteed, as the latter can be misleading.
Yeah, great point. So my interest beyond preterm optimization is neonatal ventilation, and kind of led the group that went out across the network. As a clinician on my ward round, there is nothing that infuriates me more than that phrase, "This baby did not tolerate volume guarantee or volume targeted ventilation." It's simply not true. It's us as clinicians, we haven't set it correctly. That baby might not have the right PEEP for the current compliance state of their lung. They might not be on the right tidal volume for the disease state that they have. 100% of our babies that come from delivery suites who go onto a mechanical ventilator will start on volume guarantee, and nearly 100% will remain on volume guarantee. We very occasionally might switch a baby's volume guarantee or volume targeting off, but that would be under very, very specific situations. And it's very, very few and far between. We have no difficulties managing babies on volume guarantee.
Great. And there's another questions coming up. Would you see a lot of them, by the way? We're not able to answer all of them, I believe. We can get back to you later on. And there's another one from Iran. Do you find it difficult to get a radiant warmer close to operating table without interfering with the stereo field in case of else?
Yeah, great question again. So when we bought this Lifestar trolley in, we had to do a lot of simulation with our obstetric colleagues and in theatre as well. And we have what we call a Mayo cover. So essentially it's a sterile drape that goes over the end of the Lifestart trolley. We put our transwarmer underneath before we put the drape on. And then the NeoHelp bag, which I showed you, that little plastic hoodie that we put the baby in, is actually sterile. So that can sit on the top. So the bit of the trolley that you are kind of shoving into that sterile field has got a sterile cover on. The obstetricians are very used to us now with the Lifestart trolley, and they will actually, at the right time in the section, they will reach out, grab the end of the Lifestart trolley and kind of pull you in towards the baby. So the team is very, very happy with it now, but we only got there through simulation, talking about it, working out what works best for us. So that's how we do it.
Great, thank you. So we have last 2 minutes, and I see a hands up. ZP, are you able to unmute yourself? And let me do this. If you want to have a discussion here, a live discussion, that would be great.
Hi, Tippy Dolphin.
Hello.
Hello.
My question is, you didn't talk about the early administration of surfactant. Is there not in the first line?
Yeah, so yeah, it's a good question. It's not one of the national preterm optimization intervention measures, and not something that we get monitored on how much we do or don't give. We do routinely give early surfactant. So if our preterm babies are either intubated in delivery suite, they'll receive surfactant immediately, or if they come over to the unit and they are clearly struggling with respiratory distress syndrome on non-invasive ventilation, then we would, if they're under 32 weeks, we would use Lisa. If they're over 32 weeks or they are becoming more unwell, then we would intubate them and give surfactants. But we don't monitor it as part of our preterm optimization data.
Thank you.
Okay, awesome. One last minute. I do see a question here regarding mother's pit stop. Do the moms get well done post C-section on a bed? Correct. You have the large space in your NICU for mom to get neatly to baby incubator site. Sadly, in my unit, there are 6 babies per room and only limited space between incubators. Moms in bed will not get near. Any suggestion solutions?
Yeah, so I understand that we're in a very lucky position. Our previous unit prior to 2019 sounds very similar to what you're describing there. Graham, we used to have 6 HG babies crammed into a very tiny room with parents often sat up against a bin or a sink, or there was very limited room. So the only real way that we can think about doing that, and we have chatted about this, is to, when mum is well enough to come over, if she's in a chair rather than a bed. But granted, if she's just had an emergency cesarean section, it's very, very difficult. I would just really implore that they get mum over at the earliest opportunity on a chair to come and see the baby, to try and get that early milk, if there's not the space to facilitate doing that straight away in a bed.
Great. Awesome. Thank you so much. We do still have a lot of questions, but we're on top of the hour. I believe, so I can see the momentum, and a lot of people are really interested in this topic. And I do believe a lot to be discussed as well. A lot of different practices all over the world, let's say. You all have seen Alex's email address as well. I guess if you have any further question, you can also approach to him. We will also send out the recording for your information so that you are able to reach out to us as well if there's any further questions or support that we are able to give you from G Healthcare. So thank you again, Alex. Thank you for everything. This is really great, and I can see people are happy with the contents you're delivering as well. And thank you all for joining today. And don't forget, this is going to be prematurity day very soon, next Monday. And yeah, thank you again, Alex. We'll keep in touch, and let's bring moms and baby home healthy together.
Thank you.
Thank you, Alex.